Right, I will keep going then, okay? And keep my fingers crossed that you can actually hear me.
Okay.
So I'm going to cover something about the difference between treatment-resistant depression and difficult-to-treat depression. And start off by saying something about what the problem, as I see it, for clinicians is with the term treatment-resistant depression. This is data from the STAR-D study from the United States, where 3,500 patients were treated first line with citalopram, and if they didn't respond to that, they had a number of treatments they could try at step 2, and if they didn't respond to that, they could have a number of treatments that they could try at step 3, and so on to step 4. The usual definition of treatment-resistant depression is lack of response to 2 adequate trials of 2 different antidepressants. So in other words, everybody that had not responded by step 2 in STAR-D would be defined as having treatment-resistant depression. Now, there's a number of things that you need to just be aware of when you are thinking about TRD and using this term. The first is that non-response in TRD is assumed to relate to pharmacodynamic or pharmacokinetic issues with a drug. That is assuming that the patient is actually taking the drug. Pretty much all definitions of TRD are based solely upon lack of response to medication. They don't tend to include anything to do with psychological therapies or to do with neurostimulatory treatments. So the notion is that if the patient is taking the medication and they've not responded, you need to try another one. That sounds fair enough, at least for a while. In the United Kingdom, we've got over 30 antidepressants licensed for use, and we have national guidelines that include 7 different first or second line pharmacological augmentation strategies. If we just tried half of the antidepressants and 4 of the augmentation medications, and we looked at all the various different combinations of those, and each trial was just for 3 months to allow for increasing doses and decreasing doses before you switch medication, this would take a total of 15 years to trial. And one could ask whether that is sensible. As Einstein was reputed to have said, insanity is doing the same thing over and over again, expecting different results. The point here is that most of the medications we currently use work on monoaminergic systems, on 5-HT and norepinephrine. The next point about TRD is that TRD assumes that depression is an acute episodic condition, and that if we get the acute treatment correct, then patients get better, they go into remission, and when that is sustained, they have recovery from their episode of depression. But what we know is that many patients have a non-response and their depression ends up being chronic. Some patients have a partial response and get stuck with a partial response, so they still have some symptoms even though they've improved from the initial presentation. That can even be to the point of meeting criteria for response, but they still haven't recovered. We also see patients who have multiple episodes because of relapses and recurrence. And if you spend any time in the clinic seeing patients, you'll know that there are plenty of patients whose symptoms wax and wane. They go up and down depending upon circumstances, often in the patient's life. So that's another issue with the basis of TRD. TRD thinks about depression as being an acute episodic condition when it isn't for many of our patients. TRD also is just focusing on this lack of response. This is looking at the remission rates. So anybody that's not in the red bar here would be defined as not going into remission, and therefore they've not responded well to the treatment. And what we can see is that remission rates go down with treatment step. STAR-D also looked, though, at relapse rates. And in the 1 year, just 1 year, following response to treatment, there were staggeringly high relapse rates of between 40 and 70%. This was a real world cohort of patients in STAR-D. They weren't a more rarefied collection of patients, sometimes recruited into clinical trials. And what you can see is that relapse rate is increasing with the difficulty of actually treating the depression. STAR-D also looked at tolerability and found increasing intolerance with treatment step. That was by design. First-line patients were treated with a well-tolerated drug, citalopram. Less well-treated drugs were reserved for steps 3 and 4. But what we've got here is 3 routes into a poor outcome for depression. When we're in the clinic struggling with our patients, it isn't just lack of response. It can be lack of sustaining this. So in other words, the patients are relapsing, or it could be due to intolerance to the treatments we're trying. And that's the case for medication, psychotherapies, or neurostimulatory treatments. So what is difficult to treat depression? This is a newer concept and phraseology, DTD, or difficult to treat depression. And recently, it was a consensus group came together and came up with the following definition, that it is depression that continues to cause significant burden despite usual treatment efforts. That is vague. It is intentionally vague. It is more vague than the definition of TRD. And it's comprised of 2 components: a continuing burden, which is defined by the patient. And that burden may be because of problems achieving remission, but it could be due to problems sustaining it, or problems with intolerance or non-adherence, or rejecting the very notion that they have depression and need treatment. And it may be reflected in symptoms or side effects or impaired quality of life. It's a much broader concept than we might think about simply as reduction in symptoms when we're thinking about TRD. The second part of the definition is that this burden is continuing despite usual treatment efforts, and that's defined by the clinician. And it's influenced by their expertise in managing depression, the healthcare setting where they're working, the local guidelines, national guidelines that they're working with. And it's recognizing the clinical reality of the situation. The patient has got ongoing burden despite what I would normally do to manage somebody who is suffering from depression. So to compare TRD with DTD, there's clearly different words we're using to describe it. The intention, whether it's achieved or not, I don't know, but the intention is that the difficult to treat term is meant to be less nihilistic. When we say somebody has treatment-resistant depression, it can sound nihilistic. It can also sound like you're blaming the patient or the illness. Difficult to treat is recognizing that it is something is part of the collaboration between the patient and the clinician. It is difficult for us. It's not just a problem for the patient. And difficult doesn't equal impossible. It's not just defined on the basis of failure of an acute treatment. It's lack of response or lack of sustaining this or tolerating treatment. And it is based upon a chronic illness model, or how we manage it is based upon a chronic illness model, similar to what we might do managing hypertension, diabetes, rheumatoid arthritis. Now, treatment-resistant depression, TRD, does have utility. It is important for defining populations of patients where we may be comparing efficacy of different treatments in trials, such as for regulatory authorities. Whereas difficult to treat depression and the model of care behind it is targeted at the clinician. It's meant to be providing a roadmap of how to manage this situation. Has 3 goals: symptom improvement, prophylaxis, and improvement in quality of life. And rather than simply just saying further acute treatment trials, which might be appropriate, it's actually saying what we need to be doing is saying, stop, hold on. Why has this person got depression? But even more importantly, why is this depression proving difficult to treat? If we can find some reason why the depression is not responding well that we can do something about, we may be able to turn a difficult to treat depression into a less difficult to treat depression. So, for example, the patient may have underlying hypothyroidism. And if we treat that, the patient's depression may prove more tractable. It might be a woman who's perimenopausal, and treating that may make the depression more easy to treat. It could be the patient has got a past history of trauma, and addressing that with psychological interventions, eye movement desensitization reprogramming, EMDR, again, might be something that would be helpful. And then the treatment of the depression may be more successful. So a fundamentally different approach. It's not just trying treatment trial after treatment trial after treatment trial. So clinical implications, I've sort of already emphasized this, but to emphasize it again, in the paper where we came up with a definition in a consensus group, we also proposed a model for the management of difficult to treat depression. This is published in an open access paper, freely available to anybody, and it is written for clinicians. It's not meant to be a theoretical piece of writing. It is meant to be there to be practically helpful. And in this consensus, we emphasized three major goals. Firstly, and perhaps most obviously, we want to have optimal symptom control, and we want to get patients into remission if we can. But we recognize that in the first instance, that might not necessarily be achievable. Secondly, we want to reduce the risks and impact of relapse, because what we know from the STAR-D data is that patients that are more difficult to treat, or their depression is more difficult to treat, have a higher rate of relapse. And thirdly, and perhaps most importantly of all, we want to be optimizing psychosocial function, because that is what is most important for our patients. So how do we do that? Well, we start off with a good assessment. Every bit of medicine across the whole of medicine should always start with a good assessment of our patients. In the paper, we made a number of recommendations with regard to investigations that can be done, either in primary care, family medicine, or in more specialist mental health care. There's nothing particularly clever about this list. It's in the paper, and you can see it in the paper. But there are then critically three steps. Firstly, thinking what the differential diagnosis is. Just checking, could this be bipolar depression? And that is why the patient's not responding to an antidepressant. Number two, identifying and treating comorbidities, because this is the biggest reason why depression proves difficult to treat. There is some comorbidity, and it could be a physical health problem, such as hypothyroidism. It could be a comorbid psychiatric problem, like anxiety disorder. It could be a substance misuse problem, like comorbid alcohol. Or it could be a psychosocial problem, increasing deprivation and poverty. It could be iatrogenic as well. It could be some medication the patient's taking. Thirdly, we want to identify the predisposing, precipitating, and perpetuating factors, not just for the depression, but for why it's proving difficult to treat. This is trying to understand what it is we might need to try and address to turn a difficult to treat depression into a treatable or less difficult to treat depression. In the paper, we came up with 8 steps in terms of the management of difficult to treat depression. I'm actually only going to look at the very last one, because this sort of encapsulates the whole principle of managing DTD. And this is shown here. It really says, in every time you review a patient, going back to square one again, formally assessing the severity of the symptoms. Remember, measurement-based care, where we measure the severity of patients' symptoms while we're treating them, has been shown in several studies to lead to much better outcomes for our patients. We want to understand the impact on psychosocial function because this is one of our targets in our treatment. We want to reconsider the diagnosis, make sure that we're always asking the question, have we got the right diagnosis? And we want to screen for comorbidities and treat them when we can. And then reviewing any other factors that might be making the depression difficult to treat. Then systematically going through and asking the question, are there any medications that can be withdrawn? Remember, any patient with any type of health condition that is proving difficult to treat, be it diabetes or be it depression, the more difficult to treat they are, the more they attract more and more medications like magnets. That in itself causes a burden for our patients. So if there is treatment that's not working, or even worse, medication that's making things worse, get rid of it. Number two, only after you've done number one. Number two, are there any medications that could be optimized? For example, increasing their dose if the patient is tolerating it and there is some evidence of a partial response, try increasing the dose. Number three, again, only once you've done number one and two. Number three, are there other medications that you want to think about, either switching the antidepressant, for example, or adding other medications in? Next step, it's not just about medication. We need to think about all management options, medications, psychotherapies, neurostimulatory treatments such as ECT, TMS, and psychosocial interventions. And I would add into that list self-help. There's a lot of online self-help tools for anxiety, sleep problems, which again, addressing those can make the depression easier to treat. And then finally, is referral to a highly specialized service warranted? There are an increasing numbers of treatments that are very specialized. One that I'm interested in is surgically implanted vagus nerve stimulation. Now, that is not going to be a treatment that every psychiatrist is going to use, or even every psychiatric hospital is going to have available. So you need to be aware of what treatments there are so that these can be considered in a timely way for your patients who've got particularly difficult to treat depression. So when you are getting stuck, ask the question, do I need to discuss this with a friend or colleague? Do I need to go to a case conference and present the case to get others' ideas as to how we might be able to move forward? Or do I need to actually refer, if available, if there is a clinic available, somewhere where the patient may be able to have further assessment and opportunities for other treatments? So I'm going to conclude by just saying, reconceptualizing treatment-resistant depression as difficult to treat depression, I think it has semantic advantages. It emphasizes the collaboration between the patient and the clinician. I think the model behind it has important management implications. Everything starts with a thorough assessment and frequent review. And you need to follow some key principles and management steps. That includes screening for and treating comorbidities and using medications and treatments in a careful, systematic way. And this model isn't just applicable to depression. It works for bipolar disorder. It works for schizophrenia. Why? Because this was based upon a model of care that is used for chronic rheumatoid arthritis, chronic hypertension. So this is just looking at how we apply good clinical practice to situations where we are finding difficulty. Thank you very much indeed.